Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of experts. Jefferson Comprehensive Weight Management offers a full range of surgical options for weight management. We understand that being overweight is a chronic condition that requires long-term care and committed treatment, as well as respect and compassion. Well, thank you so much for submitting in your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Gintas Antonovicius, also goes by Dr. G with patients. Dr. G is a bariatric surgeon, medical director with comprehensive weight management out of Jefferson North Abington. And we also have Dr. Janine Carrillos with Jefferson Comprehensive Weight Management. Well, thank you both for joining us this evening. I'm going to go ahead and give each of you a minute or two to just say hello, provide a little background information about yourself, and then we will dive into the questions. So Dr. G, we'll go ahead and start with you. How are you doing this evening?
All right. Good evening, everyone. So it is a pleasure really to be here tonight. And I appreciate the opportunity to speak to all of you. As you said, my name is Gintas Antonovicius. It's not easy to pronounce my last name. So most patients know me by Dr. G. So I dedicated all my life and all my career to helping patients to achieve their healthier lives through the mostly surgical options and surgical interventions of obesity. I currently serve as chief of bariatric and bariatric surgery division at Abington Jefferson. I'm also medical director for the Jefferson Comprehensive Weight Management Program at Abington Jefferson North. I'm board certified. I'm also fellowship trained. And since 2008, I have been member of the Abington family, Abington Jefferson. So over these 2 decades since I joined Abington, I performed pretty much around 4,000 of bariatric operations, including Roux-en-Y bypasses, duodenal switches. And duodenal switches actually are a big portion of my operations. SADIs and vertical sleeve gastrectomies and many revisions as well. So I'm looking forward to discussing all these latest advancements in bariatric surgery. I'm very excited to share my expertise, and I'm probably going to learn something from all of you as well.
Absolutely. It will be a great discussion. So thank you. Okay. And turning now to Dr. Carrillos, how are you doing this evening?
I'm great, thanks. Thanks for having me. I always love talking about weight and obesity. It's really a passion of mine. I've been an internist for over 25 years, and I've spent the last 10 years specializing in obesity medicine. So I'm not a surgeon. I'm a internist, medical doctor, and I'm the enterprise lead of the comprehensive weight management program, and I treat patients for medical weight management. And we collaborate very closely with the bariatric surgeons, taking care of patients beforehand and maybe referring to them, taking care of a lot of patients afterward who are continuing to address their obesity. I'm also associate professor of medicine with Jefferson University. So very involved and very excited to be here.
Okay, well, thank you both. And let's get to the questions. And just so everyone knows, we're going to go ahead and structure tonight's submitted questions by first diving into all things surgical with Dr. G, and then we'll switch over to questions relating more to medication side of things with Dr. Carrillos before then turning to our live questions. So without further ado, question number one. Dr. G, this one is for you. How is it determined that bariatric surgery is an option for the patient, and when does surgery become a needed option?
Well, so this is an excellent question, and it's basically about indications, right, for surgery. So, first of all, to qualify for surgery, you need to meet some certain criteria. And these criteria actually, insurance companies have these guidelines, and we have two sets of guidelines actually. One is the older one since 1991. National Institute of Health defined these guidelines, which basically says that a patient needs to be with at least body mass index of 35, but if they between 35 and 40 you need to have some additional medical problems or which we call comorbidities, things like diabetes, hypertension, high cholesterol, or sleep apnea to qualify for surgery. Now, if BMI is more than 40, then you do not need to have any comorbidities or medical problems. You should be qualifying for surgery by these guidelines. Now, recently, is since 2019, I believe in 2019, there came out the new guidelines from our societies, American Metabolic and Bariatric Surgery Society, and also International Federation for Obesity. They released new guidelines which pretty much lowered the indications by 5 points, saying that if anybody is between 30 and 35 BMI with medical comorbidities, actually should qualify for surgery. And if anyone is above 35 BMI, even without medical comorbidities, they should be qualifying for surgery. So it is interesting that guidelines came out really long time ago, since 2019, but not all insurance companies actually adopted all these new guidelines, and most insurance companies still kind of go by the old rules. But remember, the indications for surgery is not just what insurance actually is guiding you through what kind of indications you should have, but it's also about being healthier, about living longer life. So it's not just the numbers, but in reality is actually more than that. So you want to resolve your serious health conditions, you want to have better quality of life, and you want to live longer. So I think that would answer this question.
Absolutely. Thank you for walking us through that. I think the next follow-up question there is, how do you pick the right surgery for you? And I know that's probably a big question.
Right. So that's excellent question. To pick the right surgery is not really an easy task. It may seem like it's actually pretty straightforward, especially if you are on like Facebook groups or you talk to other patients. It seems like very easy to decide, and most people are going to say, vertical sleeve gastrectomy, and that's it. But I think you first, whatever we're deciding about surgery, the first thing is to actually choose the center which is doing bariatric surgery, but is doing bariatric surgery with all types of operations. So that you have tools that you can choose actually from all types of operations. So it's not just sleeve or bypass, but you have also in your armamentarium duodenal switch and SADIs and all newest technologies. So that's number one, a first step where you want to make sure that your decision is going to be right. So then when you have consultation with surgeon or any provider in the center, so the couple big things going to matter which surgery actually is the best for you. One is your starting weight or body mass index. And then, second, or also as important, is your comorbidities or medical problems. So, as for example, if your body mass index is really high, and we consider high more than BMI 50, so then these less aggressive operations, I call less aggressive operations like sleeve gastrectomy, they may not be actually the best option for you because the weight regain in these type of operations with starting high weight is going to be significant. It might be up to 50% chance that you're going to regain weight. So you really need to know that either you're going to need some additional help or it might be actually that maybe your goal just to get rid of let's say 10-15% of your total body. But you need to set up your goals correctly. And then, for example, in BMI 50, BMI 40s or so, sleeve gastrectomy is perfectly fine, and that's great and effective operation where most people are going to lose weight and they keep it off in this range of BMI where the chance of regaining is only maybe 10% or so. So, and next big category, which I was saying previously, is your metabolic problems or medical problems. Like, for example, if you have diabetes, diabetes is a big one. So, if you have diabetes and you choose or somebody suggests you to have sleeve gastrectomy, for example, your chance of resolving diabetes is going to be about 60%, which is not bad, but there are some better options. Like SADIs or actually even bypass will give you about 80% chance of resolution for diabetes. SADIs will give you 98% chance of resolving diabetes. Indodinal switch pretty much in the same range, 98, 99% of resolving diabetes. So I think it is so important to actually talk to experts and try to put all this puzzle together to really get the best option and best outcomes. And at the same time, you want to make sure that you get, it done safely and in a facility or in a center where you have team and you have support.
Absolutely. And can you go into revision surgery a little bit more? Is that always needed?
Right. So, revisionals, to answer the question, I think short answer is that revisions sometimes are needed, yes. But do they always, is a right answer always to have revision? Maybe not. And it depends on the situation. Because revisions in general are very complex decisions. We always tell ourselves, what exactly is happening? Is that surgery failed or patient failed? So which one is actually first? But to determine that, we actually really need to look into why we are seeking revision, because revision is like a big, big category. Now, one big category is that patients have some kind of symptoms. So if you have symptoms, something like chronic nausea, vomiting, maybe reflux, maybe even aspiration events, bowel obstruction, maybe severe nutritional deficiencies, maybe vitamin deficiencies, then it's one set of problems which we can address with potentially fixing some kind of anatomical problem. And that most of the times in these type of situations, when you have symptomatology, some kind of negative symptomatology, it's usually some type of anatomical problem. So that's one of the set of the revisional surgery. Now, the second big thing is weight regain. Obviously, when patients come in for weight regain, the biggest question is, again, number one, is it anatomical problem? Because sometimes you can develop for example, fistulas between your small pouch and reconnection back to your gastric remnant, which is called gastrogastric fistula. If that, for example, happens, that's anatomical problem that also could be fixed surgically, and revision could be appropriate thing to do. Now, to determine if it's anatomical problem or is it kind of combination of the surgery maybe failure in general, you really need to have good evaluation. That's kind of first step. And obviously to see expert who is not a rookie surgeon, but somebody who is really has expertise. So you need to have good evaluation. So usually I would do at least 3 tests to determine what options patient would have. So that would be endoscopy, upper GI, and then CAT scan. So these 3 tests are going to tell me exactly what the anatomical situation is, and then we can talk about potential revisional options. So if let's say your anatomy, everything is perfectly fine with your bypass or whatever surgery you had, sleeve. So then we're talking about potential conversions to different type of operations. And conversions could be just a few examples. Something like, for example, from sleeve to convert to gastric bypass, from sleeve to convert to SADIES, from sleeve to convert to duodenal switch. Or we also do even more complex operations from bypass to convert to duodenal switch. This is probably the most advanced, most complex operation, whatever is done in bariatric world. But conversion from bypass to duodenal switch is also possible, and we do these operations in our center. So the best decision sometimes is not just to have surgery, but maybe actually to go to a medical arm and try some medications, which as you're going to see a little bit later, Dr. Kyrillis is going to talk about medications. We have very powerful medications, and that sometimes is the right answer. So very complex decision, but make sure you see the expert. Make sure that you have good evaluation and make sure that you have all options available that you can choose the best option.
Absolutely. Great advice. Thank you. And I want to follow up quickly on something you mentioned, the SADIE surgery. Can you just talk a little bit more about it and what are some pros and cons to this option?
Yeah, so thank you for that question because SADIS is relatively type of new operation, and the SADIS means actually single anastomosis duodenal with sleeve gastrectomy. So as you can imagine, just from the name, that actually there is a part of this operation is a sleeve gastrectomy. But besides sleeve gastrectomy, you also have one connection, which is a little bit different than in full duodenal switch, where you have 2 connections. So it is one connection duodenal switch, in other words, or modified duodenal switch. So it has many names, but most common name is actually SADIES. So single anastomosis duodenal ileostomy with sleeve gastrectomy. So the procedure first was introduced actually by a Spanish surgeon, Dr. Antonio Torres, and then it was popularized in the United States not that long time ago by Dr. Daniel Codham. Our society, Bariatric Surgery Society, recognized this operation a few years ago as a standard operation. So it is a standard operation. Unfortunately, some insurance companies still not recognizing that as a standard operation, and they denying these operations still. So a lot of times patients need to choose, instead of getting SADIES, maybe to go to more aggressive option, which would be duodenal switch, or less aggressive option, which would be a sleeve gastrectomy. But the positive things about SADIE is that the resolution of diabetes goes up to 98%. So which is huge. Diabetes resolution is pretty much almost guaranteed that diabetes would be resolved or cured, and patients would not need even medications for diabetes, and sugars would be normal. So the other big advantage of SADIES, especially comparing to duodenal switch, there's less chance to develop vitamin deficiencies or even protein problems. So because you have much longer channel comparing to duodenal switch. It is somewhat simpler procedure. That's another benefit of SADIES. And it is good option for somebody who has a little bit lower BMI, let's say in the range, below BMI 50, but also has diabetes. So that would be kind of ideal candidate. And negative things, well, again, like with any surgery, you can have some side effects. You still can have vitamin deficiency sometimes, especially in patients. Patients are not compliant with supplementation or the vitamin recommendations because it has anastomosis. There is a potential possibility of developing internal hernias, strictures, or things like that. We're talking about less than 3% at the time. Patients can develop something like that. But yes, it's very good and very promising new option. Not covered always by insurance yet, but some insurances started already covering.
Okay. All right. Well, that segues into our next question, talking a little bit here about coverage and cost. So is weight loss surgery covered under insurance if you have diabetes? And are there different surgical options for diabetic patients?
Right. So, well, again, it's another great question, but we're talking a lot about insurances. It sounds like insurance is kind of regulating what we're doing, but in a way, it is somewhat trying to give some guidelines for patients as well and for the physicians. But and indications for these surgeries actually is weight loss. So it is not diabetes, not hypercholesteremia, not any of these metabolic problems, but is a weight loss surgery. So weight loss is an indication for weight loss surgeries, right? Even though with these operations and resolving obesity, we resolve all these other medical problems. But diabetes alone is not an indication to have these type of operations. And numerous times I had patients with BMI, 30 coming with diabetes, and yes, we cannot actually offer these patients SADie or anything like duodenal switch or even bypass. That's kind of sad, but that's how it is. Now, the cost of the surgeries, again, if insurance covers, obviously that depends on your insurance plan. But if insurance does not cover, we have some private pay options. Just as example, I mean, I don't want to put too much details in how much it costs, but for example, at Abington, to have sleeve gastrectomy, everything included, is somewhere around like $12,000 or so. And I know that it ranges between in the entire United States, it ranges between like 12 and 15, $16,000. So that's one example of these operations. Now, what are the options for diabetic patients? Right. Well, again, assuming that BMI is in the range where you can have these surgeries, so the best options for diabetic patients are these, which we call diversionally operations. So diversional operations are the ones where we're rerouting your GI tract. And rerouting GI tract involves in gastric bypass, it involves in SADie, and it involves in duodenal switch. So the resolution of diabetes with these operations with bypass goes about 80% or so patients resolve diabetes. With SADies, we're talking about 98%, and with duodenal switch, 98, 99% resolution of diabetes. So there are options, but remember, indication is not really diabetes to have these surgeries, but obesity is the indication.
Okay. All right. Thank you. And final question here before we turn over to Dr. Carrillos. Do you mind just talking a little bit about what recovery in general looks like?
Right. So recovery nowadays, when we do these operations, actually with minimally invasive techniques and especially robotically, recovery is really fast. It's amazing, how much progress we made for the last, few decades. When these operations used to be done open way, then recovery was definitely about a week or so, and nowadays we're talking about recovery in 1 day or so. Patients actually are already back to regular activities. But just to start kind of talking about from very beginning, when the operation happens, the operation itself usually takes for sleeve gastrectomy takes about 1 hour. For bypass takes about 2 hours, and for SADIES about 2 hours. For duodenal switch about maybe 3 hours. So when patients wake up, from surgery, they have only like 3, 4, 5 band-aids. So our patients stay in the hospital. Most of patients stay in the hospital just one night. But even before leaving home, um, pretty much in a few hours, in about 4 hours or so, you're going to start getting liquids to drink, and you're going to be getting out of bed and walking around. So pretty much in a few hours after surgery, you're already moving around and ambulating. So then going home, pretty much in one night, you go home and back to regular activities or like regular chores at home, and so you go back into about 2 or 3 days. And usually we recommend not to lift anything heavy for another 3 weeks or so. But in about 3 to 4 weeks, you will be back to absolutely everything, whatever you were doing before surgery, even strenuous exercises and so forth. So very fast recovery, really minimal pain. We're using, all multi-modular medications to actually help you with pain. And especially during operation, we also do blocks, nerve blocks. So really minimal pain, very fast recovery.
Okay. All right. Well, thank you. Let's turn now to talk a little bit about medication. Thank you, Dr. G, so much for all that helpful information about surgery. And I know we'll probably get to a few more questions in our live portion. But for now, Dr. Kyrillos, let's talk about medications. So what are the different options, and what are some pros and cons to these medications?
So medications are all the rage now. Everybody wants to know about these weight loss medications, and you see it on social media and on television. The newer medications are really very effective. Weight loss can be 15, 20, 25% of total body weight. So 300-pound guy could lose 60 pounds, which is really incredible. It not as much as you would lose with surgery, but you still have a very good outcome for a lot of patients. Um, they help with the brain to decrease appetite, to decrease craving, to help you feel more full. They work on several different levels to help with that. And some of them also work on insulin and glucose metabolism, which are responsible for weight gain. Sugar drives insulin, which then drives weight gain, and so finding ways to even out those levels can be really helpful, and these meds can do that. The cons, well, like any medication has side effects. Some of the newer meds have, if they work too well to decrease your appetite, and things go backwards, you can get nausea, reflux, some gastrointestinal symptoms. There's some other rare side effects. People are hearing all over media about stomach paralysis and thyroid cancer, and really these medications have been studied rigorously, and any severe side effects are very, very low. Another big con is cost. The newer medications are very expensive. So I commented to myself when Dr. G said that the sleeve gastrectomy is $12,000. Well, that's a year of medication. So if the sleeve gastrectomy keeps your weight off for 10 years or longer, might be cheaper, unfortunately. And I'll talk a little bit later too about some of the challenges with the cost.
Okay. All right. Well, thank you. Yeah. And I guess as a follow-up there, talking about cost and coverage, what are some options if insurance won't cover anything weight related unless someone is diabetic?
Right. So there are medications specifically for weight loss. So the brands like Wegovy and um, Zepbound are specifically for weight loss. The same exact medications are used for diabetes with a different name. So Wegovy is for weight loss and um, Ozempic is for diabetes. And the insurance companies won't cover one for the other reason. So if you have diabetes, but your weight is lower than a certain amount, I'll tell you in a minute what that means. They won't cover Wegovy, but they'll cover Ozempic. And then the same thing, if you have obesity, they won't cover the diabetes medicine if you have diabetes. So it's very confusing for patients because they call their insurance company and they say, oh, well, it'll be covered, for this, and it becomes very confusing. I should go back and talk about indications for medication and who qualifies. So the body mass index, Dr. G was talking about that earlier. It's a calculation using your weight and height to, estimate how overweight you are. And there are actually, some new articles and new studies looking at other measures of obesity besides BMI, but that's what we're using now. So body mass index of 30, you qualify for medication. Body mass index of 27 with diabetes, hypertension, sleep apnea, some of those other issues, then you also qualify. So surgery is 40 by itself and 35 with other comorbidities. Medication is 30 by itself and 27 with other comorbidities. So if they're not covered, so there are other medications for weight loss. There are several other medications. And some are very cheap. Phentermine is an old-fashioned appetite suppressant. It's very safe. And you can get that for about $15 a month. Unfortunately, a lot of providers aren't as comfortable prescribing it because it has a lot of history. But that is a great option for a lot of people. We'll use off-label meds like metformin. Even though it's a diabetes med, it can help with weight loss. There are other brand name meds that are a little more expensive, but with patient savings cards, they can get them for $99 a month. There is out-of-pocket cost for the Wegovy and Zepbound, and those meds is $650 a month for a lot of those meds. What else can you do? So looking at what other diagnoses may qualify. So recently, some of these weight loss meds have been approved for other reasons besides weight loss. So Wegovy last year became approved for cardiovascular risk reduction. So for patients, and it's very specific, for patients who have had a heart attack, had a stroke, or have peripheral artery disease, then Wegovy is indicated for cardiovascular risk reduction. So now Wegovy is not a weight loss med. Now Wegovy is a cardiovascular risk reduction medication. And some plans will cover it for that reason. So Medicare, a lot of Medicare plans will cover it. Recently, Zepbound, tirzepatide, was approved for moderate to severe sleep apnea, obstructive sleep apnea. Excuse me. So not all the plans have picked that up yet, but I suspect that they will. So now these meds aren't weight loss meds. They are meds for other chronic conditions. And I'll mention another thing that patients can do is advocacy. Talk to your employers. Coverage of weight loss meds depends on, if your insurance is through your employer, then they make the contract with the insurance company and they can opt out of obesity medication. So unfortunately, the plans are able to refuse covering weight loss, refuse covering obesity. They can't refuse to cover diabetes, but they can refuse to cover obesity. Talk to your employer, talk to HR, talk to your insurance. Medicare does not cover weight loss meds by law. Anything that promotes weight loss is not allowed to be covered. They'll cover the cardiovascular med, they'll cover the sleep apnea med, but not the weight loss med. But there is right now a bill before Medicare to proposed to allow coverage for weight loss medications. And currently it's open to public comment. So if people actually want to be a little bit more involved and take a stand on this, they can make a comment that before to send to Medicare. I can actually put the link in the chat on how to do that and make that make your voice heard, that you really feel like it's important that we treat obesity. Um, so so those are my thoughts on that.
Yeah, thank you. Um, a lot of information. So we appreciate you walking us through that. And just that self-advocacy piece is huge. So thanks for reinforcing that. All right, let's turn to our next question here. Still relating to medications, do some patients take weight loss medications even after weight loss surgery? And if so, could you just describe why this happens?
So obesity is a chronic disease. It's a chronic condition. You know, our bodies weren't supposed to live today. We're supposed to live hundreds of thousands of years ago in the Stone Age, where you have to go hunt and gather. And we haven't evolved to deal with the food supply, the the environmental um, you know, uh, things in the environment that affect our weight, the medications that we take, the change in activity, and it's really overwhelming our system. And there's no cure for obesity. So a lot of patients go and say, surgery, I'm going to have surgery as a permanent weight loss solution. Unfortunately, it's not a cure. It's not a permanent solution, and people can regain weight. And it doesn't mean the surgery failed. You know, if you lost 100 pounds and 10 years later you gain back 50, you're still in a much better place than if you hadn't had the surgery, you might be 50 pounds higher. Um, so we need to approach this with several different modalities. So things that I talk about with patients are lifestyle changes, medications, and surgery, and not one of them is going to necessarily be the answer. You need all of them for some
Okay.
people.
Absolutely. And along those lines, you mentioned lifestyle changes. So, in addition to healthy eating, exercise, is there a weight loss medication that's particularly effective that you would want to call out to patients?
So these new GLP-1 medications, Wegovy and Zepbound, so semaglutide and tirzepatide, um, that they're really helping us learn so much about appetite and energy regulation. We're looking at these meds for addiction. I have so many patients that come and say they stopped drinking alcohol. Someone that said they don't have a shopping addiction anymore. Um, these meds are really targeting parts of the brain that have trouble regulating, and they help people regulate their appetite and their cravings. And they've really been remarkable to help people lose and maintain weight. But you do have to take the medications long term. So if you take the med and, you know, that's what helped you lose the weight and then you stop, people tend to regain the weight. It's like if you have the surgery and then you reverse the surgery, there's no cure. Um,
Mhm.
so it's something to remember.
Yeah, that's an important call out. But really fascinating about that addiction piece. I haven't heard that before. All right, let's turn back. Dr. G, we'll have a quick surgery question for you. Um, if a patient has obesity, can surgery be a preventative or medically necessary procedure?
Oh, I was muted, sorry.
No worries.
I think Dr. Kyrillos already mentioned a little bit that obesity is actually a disease, and most societies actually agree with that, which is great. So it's not just about, excess weight. It is a chronic disease which is progressively, worsening with progressively worsening medical condition. So being obese actually is a risk factor for many medical problems or medical situations. Number one, obesity is related to increased risk for cardiovascular disease and problems. Number two is stroke, increased significantly risk. Any kind of respiratory issues, including asthma or sleep apnea. Um, any of these metabolic problems, like type 2 diabetes, is one of the big ones. Uh, Even some cancers actually are increased in obesity population. Liver disease, NASH, and the fatty liver infiltration. Even mental health issues actually are increased risks for somebody who is obese. So when we're talking about weight loss in general, is it preventative or is it medically necessary? It depends on individual situation. So if somebody is, let's say, with excess weight or has obesity, and there is no other medical problems, so then it becomes more of preventative. So you are preventing because you are in a higher risk of developing diabetes, hypertension, high cholesterol. So that becomes preventative medicine. Now, if somebody has already these medical problems, then becomes medically necessary because you want to cure, get rid of these diseases, or at least significantly improve these medical problems. So in reality, really, it doesn't matter if it's preventative or medically necessary. So you really want to increase your lifespan or increase life expectancy. You want to have cardiovascular protection. You want to have good metabolic effect that actually you're not going to develop diabetes or you're going to cure from diabetes and you're going to live longer life. So I think, either way, either it's preventative or medically necessary, you're still going to get significant benefits.
Absolutely. And Dr. Krill, is there anything to add from a medication standpoint?
Um, yeah, absolutely. The treatment of obesity is medically necessary. This is not cosmetic. Um, you know, Excess weight and obesity is not a matter of willpower. If it were willpower, then 2/3 of the population wouldn't have excess weight and obesity. Um, if it suddenly 2/3 of the population had this big attack of willpower, like unfortunately in our environment and where we live, it's unavoidable. And as Dr. G pointed out, there are so many medical issues that are related to it that can be decreased or cured with weight loss. And I do want to add, we're talking about, surgery has, large amount of weight loss, medications but even a very small amount of weight loss, so even losing 5 to 10% can show dramatic improvements in diabetes and blood pressure and fatty liver disease and your asthma and arthritis, things like that. So people are saying, oh, I need to lose 50, 100 pounds, and that would be great. But even, a small amount, making healthy changes, living a healthier life, it's not like throwing the towel like, oh, I'm fat, so let's just forget about it. There's still ways to improve your health without losing a very large amount of weight.
Yeah, that's a great call out. So thank you. All right. Well, thank you both. I think now let's go ahead and turn to some of the live questions that we've been receiving from the audience. I know I've learned a ton already, so I'm excited to dive in here. All right. So I will go ahead and just read out the question, and whoever wants to answer, feel free. All right. First question here. What are your suggestions for someone who has GI issues on having surgery? And also, what about medications? So whoever wants to go first, feel free.
Well, I think as a medical professional, a physician, the devil is in details. GI issues is very broad category, so it's really difficult to tell what exactly GI issues we're talking about. GI issues could be ranging from, I don't know, someone has Crohn's disease would be a much different than somebody who has maybe irritable bowel syndrome or things like that, right? Because any of these patients will have some GI issues. So I would say the first of all, pretty much like I was mentioning before, you need to have good evaluation to determine what kind of problems you have before making decision and what kind of surgery you would want to consider or maybe would be a good option. So obviously the simplest option is a sleeve gastrectomy in any like complex situation or any complex medical problem. But we need also to be careful with the things which I mentioned before in high BMI patients, that could not be necessarily the final answer. And patients who have significant reflux or heartburn, sleeve gastrectomy also could be maybe a little bit questionable if that's the right choice. Medications, Dr. Kyrillos, maybe you can chime in.
Um, yeah, we find with medications that, they can cause some nausea, vomiting, reflux, some diarrhea, some constipation. We find that patients are more sensitive to the type of food they're eating. So the first thing we'll ask is, what are you eating? If they have a lot of processed, refined foods, they're more likely to get nauseated. If they're eating more real, protein, fiber, they tend to tolerate it better. Um, Drinking a lot of fluids can help a lot of things. Also paying attention to how fast you're eating and how much you're eating. So with surgery and with medication, you know, people don't have as much room. They don't, you know, so if you eat quickly, you don't feel full as quickly, but then suddenly, you know, you, that you're over full. So sometimes it's just a bite or two goes from feeling comfortable to being over full, and so just eating more slowly, paying attention. Stop eating when you're no longer hungry, not when you're full. Things like that can help.
Okay, thank you. All right, next question here. I think this one is for Dr. G. If a patient had gastric bypass and had nutritional deficiencies, can they still be a candidate for future intervention?
Right. So gastric bypass and deficiencies, again, if we're talking about just vitamin deficiencies is probably one thing, but if you also have protein deficiencies or malnutrition, that could be slightly different problem. So again, good in the revisions, remember, as I was mentioning in the revisions, really good evaluation is number one thing you need to do. So if there is some kind of malnutrition situation, then very likely there is some kind of problem with bypass. It's either some kind of stricture, narrowing, blockage, or something in GI tract where things may be just not going through really well. But with BMI 40, probably is unlikely that that's the situation. It's probably more of maybe vitamin deficiencies situation, right? And sounds like from the question is also that it's more vitamin deficiency than anything else. So, well, something like conversion of bypass to regular anatomy, obviously that would help to improve your vitamin deficiencies. Um, Conversion to different type of operation would be probably unlikely very helpful. But yeah, good evaluation first and try to figure out if there is anything wrong with the bypass that can be fixed. And obviously supplementation is important in any of our operations. So maybe there is supplementation problem, maybe not enough educated about the needed supplements. And that's where, again, we have our in our center or in the entire Jefferson Comprehensive Weight Management Program, we have dietitians. We have really help for patients to really be up to date with what you need to do for maintenance. So it could be as simple as making sure that you take appropriate, supplementation for bypass. Could be as simple as that.
Okay. All right. Well, thank you. Okay, next question here. Dr. Kyrillos, this one is for you. Are there any non-injection medication options or solutions for weight loss?
So there are several pill form medications for weight loss. The Contrave, Qsymia, phentermine. There's some off-label medications we use. They may not be as robust as these newer injectable meds. There is a medication, there's an oral form of semaglutide called Rybelsus, but it's only approved for diabetes. There are trials looking at it for weight loss, and you may see it approved for weight loss down the road, but right now it's not. So there are other weight loss medications that may be appropriate, combinations of meds too. So definitely worth looking into.
Okay. All right. Thank you. Okay, Dr. G, this one is for you. Can a sleeve be reset to make it more constricting again without surgery?
Good question. So I have actually patients coming in and actually asking about mostly surgery, not redoing sleep and things like that. Um, but resetting sleep is more probably the question about the diet and what can you do about changing or going back to maybe the beginning, after surgery when you had surgery, and we have like a special diet actually for any bariatric operations, and most people lose with the diet only, and they don't need even to have surgery. So to get some reset of your sleeve is mostly about going back to really good eating habits. And that's where we have, again, our dietitians on board to help you with that. If that's a situation, if that's the only thing you need, that could potentially work really well. But if there is a weight regain for some reason, first thing, again, evaluation, and trying to figure out if there is something wrong with sleeve. There are situations that, and I had quite a few actually patients who had really dilated proximal portion of the stomach, which is beginning of the stomach, for whatever reasons. It could be because of maybe surgery was constructed the way that the proximal or beginning of the stomach was left a little bit bigger. Maybe it got dilated with time from maybe carbonated drinks and things like that. Going back to good dietary habits, I think is kind of first thing to do. And that's what you can call, sleep reset. But also as important is to get good evaluation and decide if maybe there is something surgically needs to be done. In general, if you interested in some kind of re-sleeve or so, I would not recommend to have, if everything is okay with sleeve, I would not recommend to re-sleeve and make it tighter, because usually that would lead to some type of stricture or narrowing to the level that you're not going to be able to eat really much at all, and then you may go into malnutrition because you can't eat. I think again, expert evaluation is very, very important.
Okay.
And if I could
Yeah.
also add to that, um, surgery isn't just anatomic. It's not just that they're making your stomach smaller, but it works on hormones too. The hormones that control your appetite are sort of intercepted when somebody has a sleeve surgery. But over time, those hormones can, creep back up again, and it can feel like you can eat a lot more. That's where medication may be really helpful. So I have patients that can eat a lot more, and then we'll start weight loss medication, and suddenly they feel like their sleeve was reset. Like suddenly they feel like, oh, I feel like just like they did after surgery. Because there's a lot of hormonal component, not just the actual anatomical, how big it is. So that's a reason to maybe look at along with, dietary changes, as Dr. G said, but also looking at medication.
Okay. All right. Well, thank you
Maybe,
both.
maybe
Yep.
quick one more thing. Yeah, when we talk about dietary changes, I think, eating more fiber containing food and, protein containing food, you can feel your sleep much better. And I completely agree with Dr. Kirillos, the point that surgery is not just mechanical portion of the some rearrangement or maybe making stomach smaller, but also has a lot of to do with hormonal changes as well. And body is amazing that it adopts really well. And with time, no matter what you do, hormonal changes kind of go back to the old bad habits. So,
And
so
I
to
want to give
speak.
a shout out too, um, to the type of food that you're eating, like Dr. G said. But you know, certain foods make you feel full for longer, make you feel more satisfied. If you don't have much room, but then you eat chips and fries and ice cream, you might feel full for a short term, but then your blood sugar is going to go up and crash down, and you're going to be hungry again, and you're not going to feel satisfied. So you can feel physically full, but not actually quench the hunger and be satisfied. So eating more protein, fiber, even some fat. Um, fat for, I would say fat for fullness and flavor. Um, but staying away from that processed, refined food because they're going to trigger your appetite, and you can out eat bariatric surgery or the medication um, by having some of these processed foods. And I'll add too that um, you know patients do much better. The patients that change the quality of their food do much better than people that just eat less of the same. So with surgery and with medicine, they'll come back and say, "Oh, it's great. I'm just eating less, but I'm eating all the same things." It's still really important to look at the type of food you're eating and really nourish your body in the way that that's important.
Yeah, interesting to hear that. Thank you. All right, a lot of important insights, so appreciate it. Okay, so we're continuing to get live questions, so thank you. One more question here. How long does it take to see results and weight loss from surgery and medications?
Well, I will start, I guess. It's very good question because sometimes uh, patients have a little bit misconception, I guess, in regards of like how fast you lose weight after surgery. I can tell you this, that pretty much in the first month from surgery, almost everybody, it doesn't matter which operation you had, pretty much patients lose around 20 pounds. And it's interesting, and we almost we're gonna need to do actually study. We trying to construct the study about it, but it's probably more related to the diet we recommending transitional diet into back to normal diet, right? So almost everybody loses, similar amount of weight for the first month, and then after that it changes depending on the type of operation. Depends on your food choices. Again, as Dr. Kyrillos was mentioning, if you're eating the same food but less, well, then it's going to be different in somebody who's actually changing their eating habits. And plus, it depends also a little bit on your physical activity levels. And I know patients always tell me, when they lose 50, 60, 70 pounds, they become much more mobile and they are able to exercise much better. And that also adds to your weight loss. So the weight loss itself depends on so many things. But, with either surgery or medications, we can actually jumpstart for you with a new lifestyle and new eating habits. So the first month we talked about 25 pounds. Then first 6 months we saying that you're going to be losing fastest, but the final goal, final expectation, which we usually talk during our first visit, you're gonna get lowest weight is usually in about a year and year and a half. So it is not that fast as most people actually think. And sometimes they may be even afraid to discuss surgery because they feel that with surgery you're just gonna lose, all your excess weight in 3 months, which is not true. Actually, it is very graduate and, relatively slow, but somewhat healthy, weight loss.
Okay, all right, thank you. And from a medication standpoint,
Um, and the same thing, it really varies from person to person. Um, it is slower than surgery. It's not as much as surgery. But people want to lose weight like a straight line, straight, like a ski hill going down. And really weight loss looks like this, you know, up and down as you come down. And I, I would caution against comparing yourself because it's all over social media. Oh, I lost 200 pounds with this medication. Not everybody's the same. Not everybody's starting from the same place. Not everybody has the same resources. Um, with medications, we only look for 5% after 3 months. Most patients do more than that. But it may, and also with the medications, sometimes you have to get to the higher doses and it takes several months to ramp up to those higher doses. So you may not see anything until the fourth or fifth month. Um, so very variable.
Okay, thank you. I think that comparison piece is good advice. So we'll keep that in mind. All right, we have our last live question here, and then I just have one more question for both of you before we wrap up this evening. So last question here, and definitely a good one. How important is psychological work and therapy to success with both surgery and medications?
All right, so I can maybe start. It's interesting that someone asked this question because today we had our Center of Excellence committee meeting, and we were talking a lot about that, how important is psychological support actually before surgery, after surgery, and in general with a weight loss journey. And I think that's one of the big benefits to get your help in these centers, which we have in Jefferson Health, centers of excellence, where we have support, from behavior specialists and psychiatrists. So, number one, before even surgery, we have psychologic evaluation or behavior specialist evaluation to help determine if there is any need for any help before surgery, or maybe something actively going on that needs some issues to be addressed, and before even considering surgery. So, and then after surgery, we have also behavior specialists and psychiatrists to help all the way, from the beginning to whenever you need help. So it is very important. It's very a big part of the journey when you're losing weight, psychological therapy, psychological support, not only from specialists, but also from people surrounding you, from the family members, from everybody who is around you. If they help you, if they don't go against you, it's much easier and much better results, better outcomes if you have that support.
And also add, people think it's a great thing to lose weight and suddenly their life is going to be, changed and turned around. But there can be psychological issues with losing weight, getting more attention that you didn't have before. What's wrong with me now? What was wrong with me then that I'm the same person? Getting the extra attention and people also use weight to hide. There's you know, large incidence of trauma and abuse in people that have obesity. And so now you're uncovering that, and they may need some help with that. People use food um, to to help soothe and to help with anxiety. Well, now what do I do to help with my anxiety? So there are a lot of ways that psychological health can be really beneficial in any part of this journey.
Absolutely. I think both of what you said tonight is just clear. It's a good thing to keep in mind on this journey. So thank you. And fitting that it was brought up in your meeting today. All right. Well, with that, I want to go ahead and ask you my final question for this evening. So that is, what are your goals for everyone listening in on this webinar? What do you want our viewers to take away from tonight? So Dr. G, we'll go ahead and start with you.
Well, so I think before we wrap up, I want to leave you with one final thought. Your health is your greatest asset, and it impacts not just how long you live, but also how well you live. The ability to enjoy with your family and to pursue your passions and everything else, it's something that everyone deserves. So, and you're really not alone in this journey. We have resources. You have real help actually, and real science behind. So, and these real solutions today are available for you. So I think what I encourage you to do, to take your first step or action actually, because already you started today, by listening to us and trying to figure out what would be the best option for you. But do that next step and call us. Call our centers, and I'm sure our marketing department is going to give you options how to reach us. You can call us 1-800 Jeff now, or you can actually call directly Warminster office, actually where I'm working. And I'm not sure if I can give that number, but yeah, you can call directly, or you can actually make online appointment. And at Jefferson Health, we are number one bariatric surgery program in Philadelphia area. So, and we take that responsibility seriously, and we are committed really to give you highest quality care and with latest advancements and a team which actually supports all of that. So thank you again for joining us, and I'm look forward, to helping you in your journey.
Thank you so much. And just a quick call out, we've dropped an email and a phone number in the chat for anyone interested in scheduling an appointment. Okay, and Dr. Carrillo, any closing remarks?
Yeah, I just want to tell people that out there that are struggling with excess weight and obesity that this is not your fault. This is not a failure. There are treatment options, and they're not a cop out. Um, I use an analogy often. I can walk to Boston. It's probably not going to make it. I'm probably going to have a lot of issues on the way, or I can take the train, or I could fly. Um, it's not a cop out to use the tools that we have to treat this disease that's very difficult. Um, so it's not easy. It's very hard. No matter what approach you take, there's still hard work with it. But be kind to yourself. That's my final message, I think.
I think that's a great message to close on. So thank you. Thank you, Dr. G. Thank you, Dr. Carrillo, for your time this evening. So much great information was shared. I know I learned a ton, and I'm sure everyone listening did as well. So thank you. And thank you to you all for attending and submitting your questions. It was truly a great discussion. We will be posting an event survey so you can let us know your thoughts. Are there any other specialties you would like to hear from? If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars just like this one and more. Please also visit jeffersonhealth.org/livingwell for more health content, patient stories, research, and innovation. You can also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to hearing loss, men's and women's health topics, and previous weight management webinars. A recording of this event will also be sent to you so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.